Hello everyone. Today I am going to discuss a very important aspect in neonatal intensive care. It is about knowing all the equipments that we commonly use in newborn babies. I am Dr. Aparna, Chief Neonatologist at 𝗡𝗜𝗖𝗘's Neonatal Unit at Kondapur, Hyderabad. And I'm going to take you over through some of the common equipment that we use for taking care of newborn babies, their mechanisms of action, indications, contraindications, and few common FAQs that you may be asked as OSCEs in your exams. So let's begin with this equipment. All of you would have seen it. This is a radiant warmer. Some questions. What are the different modes that we use in radiant warmers? So there are two different modes. Now, what are the two different modes? These are the manual mode, where we set the heater output that we want to be delivered to the baby. The other mode is the servo mode. In the servo mode, we set the desired temperature, the skin temperature of the newborn infant. Usually, we set it at 36.5 degrees Celsius. This is possible by continuously monitoring the skin temperature of the baby using a thermistor probe that is placed over the right hypochondrium of the baby. So, knowing that the set temperature is 36.5, the warmer will automatically adjust the heater output based on the actual temperature of the newborn baby. So if the actual temperature is less than the set temperature, then the warmer will increase the heater output. If the actual temperature is more than the set temperature, then it will reduce the heater output. This is the servo mode. We often use the servo mode while taking care of the babies because this requires lesser adjustment in the operation of the radiant warmer. But the next question is this: when would you prefer to use the manual mode? So are there situations when we want to use the manual mode specifically? So this at 100% and preheat the linen that we will be using for receiving the baby. The other situation is when we are going to receive a new admission in the unit. Again, we will use the manual mode. Similarly, we may use the manual mode when you are dealing with a baby with fever, because when the baby has fever, then the servo mode will end up detecting higher temperature and this can result in reduction in the heat load. Next question is about the heating element. Now, the heating element in the radiant warmer, what is it made up of? There are two common substances that the heating element can be made up of, either quartz crystals or ceramide. Next common question is, how do we disinfect the warmer? So while the warmer is in use for a newborn baby, never use any disinfectant solution. Always try to use soap and water for cleaning the warmer surface. Whereas when the warmer is no longer in use, there are different ways for cleaning the warmer. We can either use wipes that are made from bacillol, or we can use bacillol solution as a spray. We also use quaternary ammonium chloride compounds for sterilizing the warmer. So these are all different modes for cleaning the warmer. It's important to avoid using alcohol over the warmer displays because this can lead to damage to the display boards. Next question for us is, what are the precautions while using the manual mode? So manual mode is the mode of the radiant warmer where we don't monitor the baby's temperature, but we only set the heater output. Now, when you have a baby who is being managed in the manual mode, especially when the heater output is high, and when one is not present round the clock, it can lead to accidental hyperthermia. So if we don't see the baby's temperature or monitor the baby's temperature frequently, we can end up resulting in inadvertent hyperthermia to the baby. And this must be always kept in mind, and hence try to use the servo mode as much as possible. Next question is, what are the different reasons for alarm in the radiant warmer? There are multiple reasons for alarm. The common reasons are failure of the heater element in the radiant warmer, where the heater element becomes dysfunctional. Failure of the probe, the temperature sensing probe that is connected to the baby. Sometimes there can be alarm due to power failure. There are some other alarms which I'll show you. So these are the different common alarms that we have. So number one is in the servo mode, when the there is a difference in the set and the actual temperature of the newborn by more than 0.5 degrees Celsius, or when there is increasing heater output, especially when we are using high heater output for more than 10 minutes, the machine alarms. Next is when there is a power failure, electricity supply failure, or a sensor failure, or per se in the manual mode, the machine will alarm every 10 to 15 minutes. Now, then the last question is about the advantages over the incubator. So there are some advantages the radiant warmer has over the incubator. Now, radiant warmer is a very cost-effective machine when compared to incubator. Most Indian radiant warmers will cost between 50,000 to 1 lakh rupees, whereas incubators can cost sometimes 6 lakhs, 10 lakhs, or even 15 to 16 lakhs based on their configuration. The other important advantage is radiant warmer has easy access to the baby. You can easily view and monitor the baby. It is simple and easy to clean when compared to the incubator. It offers both the different modes, manual mode as well as the servo mode. And radiant warmer can be used for receiving a sick baby even before the baby arrives. Can be easily used for rewarming a hypothermic newborn. And also, it is easier to perform procedures like umbilical venous cannulation or PICC line insertion while you're managing the baby with a radiant warmer. So these are all the things that we have discussed, the different modes where we use the manual mode, such as initial preparation in the labor room, rapid rewarming, and for newborn with fever. Quartz or ceramic is the name of the heater element. Never use alcohol by cleaning the warmer. That's what we discussed. Now, glutaraldehyde is also becoming obsolete in NICU disinfection. We generally use either 2% bacillocid or bacillol spray or quaternary ammonium chloride compounds. The important precaution that needs to be followed by using a radiant warmer in manual mode is to check the temperature frequently, at least once in 30 minutes in the first few hours of using the manual mode. Generally, we prefer to use the servo mode as much as possible. The next question or the next equipment is going to be the incubator. Now, we all know that incubator is particularly preferred for the care of an extremely preterm newborn, a newborn who is born for, say, for example, below 30 weeks of gestational age or below 1,200 grams birth weight. And additionally, in a newborn who requires humidification of the environment, which is not possible with a radiant warmer. However, an incubator is more expensive. It may cost up to 15 to 16 lakhs based on the configuration, whereas a radiant warmer may be available to you at almost 1/10 of this cost. The incubator also is more cumbersome to clean and sterilize because one has to take care that all the corners of the incubator are to be thoroughly cleaned with a swab. But there are some important advantages. The incubator allows us to humidify the microenvironment of the baby. You can set the relative humidity of the baby's environment in addition to the process of providing warmth. The primary mechanism of warming or maintenance of temperature in an incubator is convection, unlike the radiant warmer, which relies on the principle of radiation. Now, within the incubator, there are warm eddies of air that circulate around the baby, and this manages to keep the microenvironment of the baby warm. Like with the radiant warmer, even in the incubator, you have two modes. We have the servo mode or the skin mode, which is also referred to as the baby mode in some incubators, and we have the air mode. Now, as we understand, the servo mode is a mode where we set the desired skin temperature of the baby, and the incubator automatically increases or decreases the heating mechanism based on the baby's measured temperature. On the other hand, in the air mode, we set the air temperature of the baby. Now, based on the set air temperature and the actual air temperature, the incubator either increases or decreases the heater output. The modes of heat loss in an incubator primarily can be because of radiation. Radiation is the process of heat loss to an object which is not in direct contact with the baby. So, since the older generation of incubators were single-walled incubators and the outer wall of these incubators tended to be cold, they used to be in contact with the ambient air, the baby could technically lose heat from the baby's body surface to the outer wall of the incubator. This problem has been mitigated by the double-walled incubators, which are the newer generation incubators. So let's see some questions on the incubator. Now, what are the modes of functioning? We just discussed that incubator works on the principle of convection, and the two modes are the servo mode or the baby mode as well as the air mode. What is the concept of the thermoneutral zone? So I'll explain this with a picture. So let us look at this figure here. Now, in every newborn baby, there is a certain range of ambient environmental temperatures in which the baby will be able to maintain the body temperature or euthermia with least expense of metabolism or with least expense of energy. So look at this figure. So for this particular newborn, at a temperature zone of something like 27 to around 35-36 degrees Celsius, represented by this dark black arrow, dark black line, the baby is able to maintain normal temperature but with least oxygen consumption. So this range of ambient temperatures represents a thermoneutral zone. Now beyond this thermoneutral zone, what will happen? The ends of the thermoneutral zone are referred to as the upper and the lower critical temperature. Now when the ambient temperature crosses anything beyond the thermoneutral zone, the baby may briefly be able to maintain temperature within the thermocritical range, thermocritical zone, but at the expense of additional oxygen consumption or energy requirement. But beyond a certain temperature, the baby will fail to maintain the core body temperature irrespective of oxygen consumption or irrespective of additional energy consumption. So this range of environmental temperatures at which the baby can maintain euthermia using the least BMR is called as a thermoneutral zone. So what is the advantage of a double-walled incubator? We just discussed that in addition to convection, a double-walled incubator also minimizes heat loss because of radiation. Now, the next question is, what are the indications for using an incubator for the thermal care? Now, we have so many advantages of the radiant warmer over incubator. So, why would we prefer to use an incubator? Now, incubator is definitely preferred in some babies, such as babies who are born less than equal to 29 weeks of gestational age, less than equal to 1,200 grams birth weight, babies who are harboring infections like torch infections, which may be sometimes spread by aerosols, where we prefer to partially isolate the baby. So these are all some indications where we prefer to use the incubator, particularly in babies who are born below 30 weeks or below equal to 29 weeks, where the incidence of insensible water losses or evaporative heat loss from the skin is very high. The last question is, what are the advantages of the incubator over the radiant warmer? The incubator definitely has an advantage in the group of babies whom we just discussed, where it can reduce the insensible water losses because it can also provide humidification in addition to the regular radiation that is provided with the radiant warmer. So this is one advantage in the extremely preterm babies. Number two, the incubator also gives us the advantage of being able to provide isolation. And thirdly, the incubator would help us to kind of take care of babies who are born extremely preterm, who require more increased thermal requirement might be there. So this is the range of thermoneutral zone or environmental temperatures which are optimal for the care of low birth weight babies based on their birth weights and based on their postnatal age. So the three important parameters that determine the thermoneutral zone of any baby are A, the gestational age or the birth weight of the baby. 2 is the postnatal age of the baby. And third depends upon whether the baby is clothed or not clothed. So for example, a baby who is born less than 1,200 grams on day 1, the thermoneutral zone can be 35 degrees plus or minus 0.5 degrees. So the environment has to be so warm in order to maintain the baby to maintain the temperature. Whereas the same thing for a baby who is born at say 1,500 to 2,500 grams, over or above the 4th day will come down to around 32 degrees plus minus 1 degree centigrade. So this helps us to roughly guide the air mode while we are using an incubator. So a baby who is born day 1 less than 1,200 grams is expected to require an air temperature of around 35-36 degrees Celsius. Whereas if you see this happening with a more mature baby, like for a 34-weeker, a baby who is day 4, day 5 old, generally we may not use incubator for such a baby. But if you still see this happening, then you must be concerned that something is wrong with the baby. So these are all some indications for the use of an incubator. Another important indication is the need for transporting a sick newborn, where a transport incubator is specially used, and conditions where the ambient temperatures of the NICU might be very low. The third common equipment that we'll be discussing is the pulse oximeter or monitor. This is the monitoring device that we often use in the NICU. So in the NICU, we have two different types of monitoring devices. One is a multi-para monitor, the other is the pulse oximeter. Now, a multi-para monitor is a monitor that gives us multiple parameters such as the heart rate, the rhythm on the ECG. It helps us to know the saturation. It helps us to know the non-invasive blood pressures, We can also install a module for knowing the invasive blood pressures. Temperature module can be added to the multipara monitor. Respiratory rate can be inferred from the ECG leads. So we can have some additional parameters also based on the requirement. In addition, in contrast, the pulse oximeter is a much simpler device which only gives us two standard parameters, heart rate and saturation. Now, in NICUs, for most of the stable growing preterm babies, a pulse oximeter may be very, very cost effective. It can help us to optimize the utilization of the multipara monitor for much sicker babies. We don't really need the multipara monitor for each and every baby. So let's discuss something about the pulse oximeter. So what's the principle of use of the pulse oximeter? We'll discuss the different applications, situations in which the pulse oximeter is not reliable, and we should be discussing about the alarm limits and saturation targets for a very preterm baby. We'll also be discussing the principles of saturation screening for congenital heart disease. Now, this is a very important area that we are recently looking into. What is the pulse oximetry based screening test for congenital critical heart disease? And what are the additional pulse oximetry parameters that a rainbow set pulse co-oximeter can use? Finally, we'll discuss about the perfusion index. So first and foremost, the principle of a pulse oximetry is based on something called as the Beer-Lambert law. So this law calculates the amount of concentration of a certain chemical or concentration of a certain moiety based on the net absorption of light that has happened when light passes across the baby's limb or the baby's body part. Now, the net absorption is determined by a product of a constant multiplied by the concentration of the particular analyte multiplied by the difference between what is being emitted at one end and what is remaining at the other end. So, for example, if you know that light passes through the baby's finger, the net amount of light that is absorbed is given by the product of the concentration of the analyte multiplied by the constant multiplied by the path length. So, knowing that the path length is constant, knowing that the other three parameters are constant, we can still infer the concentration of the analyte. Here, the concentration that we are interested is the concentration of oxygenated hemoglobin. Now, we have two different types of light that every pulse oximeter emitting diode emits. One is light at 660 nanometers, which corresponds to red light. The other one is light corresponding to a wavelength of 940 nanometers, that is longer wavelength that corresponds to infrared light. It is well known that the shorter wavelength light is preferentially absorbed by, so you can remember red for reduced, this is preferentially absorbed by the reduced hemoglobin, whereas oxygenated hemoglobin has an absorption peak that corresponds to 940 nanometers. So if we know the path length, if we know the constant, and if we know the net amount of each of these two wavelengths, the red as well as the infrared wavelength that has been absorbed by the limb, by knowing the difference between what is emitted and what has been received by the receiving diode, then we can calculate the concentration of the analyte. That is what the pulse oximeter tries to do. For example, if in the receiving end, the proportion of red to infrared wavelength light that is received is 0.5, this corresponds to a saturation of 100%. Whereas if the ratio corresponds to 1, then it corresponds to saturation of 82%. So this is incorporated as an algorithm into every pulse oximeter. Now, pulse oximeter is important in clinical application for monitoring the saturation, which is considered as a fifth vital sign in a newborn baby. In addition to temperature, heart rate, respiratory rate, blood pressure, etc. It is also important to guide us during neonatal resuscitation, for titration of oxygen supply, for monitoring for apneas or hyperventilation, and also for the transport of sick babies and for screening for congenital heart disease, which we'll be discussing in detail. Now, there are some limitations for pulse oximetry. Pulse oximetry loses its reliability in low perfusion states like shock, low cardiac output states where pulse oximetry can't be used reliably. In dyshemoglobinemia, like abnormal levels of reduced as well as oxygenated hemoglobin, or when you have higher levels of methemoglobin, or when you have carboxyhemoglobin, then it loses its reliability. For example, in carboxyhemoglobin toxicity or carbon monoxide toxicity, we may have relatively normal saturations, but the patient might still become hypoxemic. Whereas in a patient with methemoglobinemia, saturations usually linger at around 85% at the lower end of normal. But you may be able to find it out from the PaO2. Pulse oximetry is also unreliable with the use of dyes such as nail polish dyes or aniline dyes and pigments. It may sometimes lose its reliability with conditions like newborn on phototherapy, where there is optical interference, movement artifacts, and in general, it loses its discriminative ability at both the lower and the higher end, especially at the higher end when saturations cross 94%, 95%. Then the baby's PaO2 can range anything from 75 millimeters of mercury to as high as 100, 200, 300, 400, because pulse oximetry plateaus beyond 94 to 95%. It can't rise beyond 100% anyway. So it is insensitive for detecting higher levels of hyperoxemia. Now, pulse oximetry has come into an important utility of late in the clinical domain, which is the pulse oximetry screening for critical congenital heart disease. Now, how do we do this and in whom do we do this? Ideally, this must be performed for every normal newborn before discharge, at least after the postnatal age of 24 hours or before discharge, whichever is later. Try to do it as late as possible in order to avoid false positive pickups like normal transitional circulation. How do we do it? We connect the pulse oximeter to the infant's right hand, that is preductal limb, as well as either foot, which is the postductal limb. So you concurrently measure the saturation from two sides, from the preductal saturation as well as postductal saturation. So if the infant has the pulse oximetry reading of 95% or more in both these limbs, both the right hand as well as either foot, then pulse oximetry screening is considered to be normal, provided we satisfy one more criteria. The difference between the pre and postductal saturation should be 3% or lesser. So if, for example, you find saturation of 96% and 97% in the hand and the leg, then this is considered as pass, because the saturations are both more than 95% and the difference is below 3%. Now, on the other hand, if pulse oximetry saturations are between 90 to 94% in both the right hand and the either foot, the difference between saturation preductal and postductal is 4% or greater, then this is considered as a suspicious screen and we need to repeat the test measurement in 1 hour. So then a repeat measurement is taken. If it falls under the pass criteria, the normal criteria, then the infant is sort of cleared as normal. Whereas in retest, again, if it is doubtful, then we repeat another measurement after 1 hour. If it is repeatedly in the same zone, that is 90 to 94%, or pre-postductal saturations more than 3% difference, then we need to get a echocardiographic screening for this baby. And on the other hand, pulse oximetry screening is clearly considered to be fail if the saturations in either of these limbs is 89% or below, irrespective of the pre-postductal saturation difference. Then we straightaway consider this as failed screening and then we refer the baby for further detailed echocardiographic examination. Now, we need to understand two things. A, this screening is not only going to detect congenital critical heart disease, but it can also pick up some non-cardiac conditions like pneumonia, newborn with sepsis. It could be a newborn with shock. Sometimes you may get false positive screening. And sometimes you may also get false negative pulse oximetry screening. So you may have some cardiac conditions which may be which may have cleared or which may have passed with the pulse oximetry screening test, and these include acyanotic heart diseases like left to right shunts like VSD, ASD. So here you're not going to find low saturations or pre-postductal saturation difference. Likewise, duct-dependent systemic circulation or left-sided obstructive heart disease like coarctation or interruption of aortic arch may also be falsely cleared or may have been declared pass by the pulse oximetry screening, but these need to be closely observed or diagnosed, detected based on a careful clinical examination. Now, the other conditions or the other parameters that we get from the rainbow set pulse oximeter are total hemoglobin content, oxygen content of the blood, methemoglobin levels, pleth variability index in addition to the carboxyhemoglobin levels. So normally in pulse oximetry, we only infer the saturation and heart rate. But in addition, the rainbow set technology gives us 5 other parameters: the total hemoglobin levels, total oxygen content of the blood, pleth variability index, methemoglobin levels, as well as carboxyhemoglobin levels. Now, finally, we have something called perfusion index, which is generating a lot of interest these days. Now, what is perfusion index? This is the ratio of the pulsatile or alternating current to the non-pulsatile component or the direct current component taken only from the infrared component of the pulse oximetry emitted waveform signal, which corresponds to the pulsatile and non-pulsatile amount of blood. So basically, pulsatile blood refers to the arterial blood. Non-pulsatile blood refers to the venous and blood in the tissue, as well as sometimes even bone signal can be picked up. Now, this ratio between pulsatile to non-pulsatile component of the infrared signal of the pulse oximeter is called as the perfusion index and gives us some idea about the arterial perfusion in that limb. Now, a lot of studies in neonatology have evaluated perfusion index as an early marker of a hemodynamically significant PDA or early marker of sepsis and maternal chorioamnitis, and this has more and more upcoming clinical utility. The next equipment that we're going to discuss is this, which is the NIBP monitor or the multipara monitor. So I have a picture here of various blood pressure cuffs that can be connected to the NIBP, the multipara monitor for measuring the non-invasive blood pressure. So let's begin with what is the formula for mean arterial pressure. Now we all know that we straight away calculate, we know the systolic and the diastolic blood pressure are directly kind of displayed from the blood pressure machine. Most of us know that a sphygmomanometer, which measures the blood pressure, has a bladder cuff that when we encircle around the patient's arm at an appropriate measured distance, the pressure within the bladder cuff increases to a certain level wherein it initially occludes the blood flow, and then there is reappearance of pulsatility, and finally we stop hearing the Korotov sounds at the diastolic blood pressure. Now we measure the systolic and diastolic, and we calculate the mean arterial pressure in most of the cases. But in invasive blood pressure monitors, we may be surprised to know that the mean arterial pressure is the parameter that is actually directly measured by these transducers. So in most clinical settings, when we use NIBP, the mean arterial pressure is calculated as diastolic blood pressure plus 1/3 of the pulse pressure. Pulse pressure is the difference between the systolic and the diastolic pressure. So if you have the blood pressure of a newborn baby to be 60 divided by 40, the difference or the pulse pressure between systolic and diastolic is 20 millimeters of mercury. 1/3 of this is 6.6. So the MAP is going to be diastolic pressure, which is 40, plus 1/3 of this pulse pressure, which is 6.6. Hence, the MAP will be 47. Now, what is the principle of use for NIBP? It relies on a principle called as oscillometric principle. Is non-invasive blood pressure the same as the invasive blood pressure? No. Usually, non-invasive blood pressure is 3 to 5 millimeters of mercury greater than the invasive blood pressure. So, you'll often find that when you connect these babies who have had a NIBP measured to an arterial line transducer and you measure the invasive blood pressure is generally 3 to 5 millimeters lower than the non-invasive blood pressure. Most of the norms that we have, such as the Zubros charts that we often use as nomograms for normative data for blood pressure, are based on invasive blood pressure. So we must be careful while using these charts for the interpretation of blood pressure measured from the NIBP cuffs, because these may not be the same. Now, what are the different sizes available in terms of NIBP cuffs? So NIBP cuffs are very similar to the adult sphygmomanometers. We have 5 different sizes of NIBP cuffs starting from 1 to 5. So these come in different sizes based on the gestational age of the baby and the measured mid-arm circumference. We decide which cuff to use. Now, the procedure for measuring the non-invasive blood pressure is as follows. First is you measure the arm circumference and choose the appropriate cuff. So the width of the bladder, not just the cuff. Note that what we are talking is the width of the bladder, which is the part within the cuff, must be generally 2.5 centimeters for a preterm and 4 centimeters for a term baby. The length of the cuff bladder, which is what goes around the arm, should encircle the arm, and certainly it should encircle or it should go around the artery that we are targeting. And we try and inflate the pressure to 50 millimeters above the systolic blood pressure that is anticipated for the baby, and then deflate slowly or decrease the blood pressures by around 2 to 3 millimeters mercury per heartbeat. And then at the systolic blood pressure, we start hearing Korotov sounds. The pressure at which the Korotov sounds start appearing as a systolic pressure, the pressure at which it dampens is the diastolic pressure. and not the pressure at which it completely disappears. It is said that the pressure at which it dampens is to be taken as a diastolic blood pressure. In contrast to this technique, the mean arterial pressure that is measured by a pressure transducer connected to an arterial line is most reliably measures the mean arterial pressure, unlike the systolic and the diastolic pressure. So these are the 5 different sizes and the arm circumference at which these cuff sizes are to be used. Okay. We'll now move on to the fifth question or the fifth equipment, which is the CPAP machine. So this is a baby who is being managed on CPAP. Now, what are the different types of CPAP machines and what are the parts of the underwater bubble CPAP and what's the principle of a flow driver CPAP? That's what we're going to discuss. So CPAP is continuous positive airway pressure. Now, this is a schematic diagram of a bubble CPAP. In a bubble CPAP machine, we primarily have 3 basic parts. This is the gas source on your left side. Then we have the patient interface. And finally, we have the pressure generator. So gas source essentially comprises of the inbuilt air and oxygen line, which is usually connected to a blender in order to blend these gases and titrate it to a certain FiO2. And then this is controlled, the flow is controlled with a flow meter. So this gas, which is the air oxygen mix coming at a certain flow, then passes through the humidifier and hence it's heated and humidified, usually heated to 37 degrees Celsius and humidified to 100% relative humidity. So this gas, which is now blended, which is at a titrated flow, which is heated and humidified, is then allowed to pass across the patient interface in order to reach the baby. And the expiratory limb is immersed in underwater seal in order to give some resistance to gas flow so as to generate a certain pressure or a PEEP, positive end expiratory pressure. Now, the interfaces that are used to deliver this pressure to the patient can be even an endotracheal tube, which was used in earlier days, but more often these days we use nasal prongs or nasal mask or nasal cannula. So this mechanism is called as a bubble CPAP and the pressure generator is an underwater seal. In contrast, a ventilator can also be used to deliver the same CPAP machine where the pressure, the resistance is given by a valve in the expiratory tubing. So the same ventilator machine can also be used for delivering both peak pressure and PEEP if the expiratory valve gives greater pressure during inspiration and lesser pressure during expiration. So as simple as that. So CPAP is a device that comprises of a gas source flowing across a patient interface and eventually a resistance being offered at the expiratory limb, which provides positive end expiratory pressure. And this pressure keeps the alveoli open or inflated, recruiting them at the functional residual capacity, which helps the baby to reduce ventilation perfusion mismatch, and this in turn improves oxygenation and eliminates carbon dioxide from the body. In addition to improving the functional residual capacity, CPAP also helps in splinting open the airway, which results in reduction in the incidence of obstructive apneas. So what we've seen is a type of CPAP which is called as a constant flow CPAP system. So here, irrespective of whatever pressure we desire to deliver, the flow that's going to the baby is going to be constant during both inspiration and expiration. We can't really change the flow during inspiration and expiration. Of course, in the bubble CPAP device, you can change the flow, but that flow is going to remain constant again during inspiration and expiration. So this model is called as a constant flow CPAP device. You have another model of CPAP, which is called variable flow CPAP. This enables us to use different flows during inspiration and expiration. How is that possible? In an example of variable flow system, which is called as infant flow driver, this is how it happens. So there is a nose piece which is designed to deliver CPAP, which has 2 different tubes. One tube which is connected to the gas flow, which is a constant gas flow, and another tube which is open to the atmosphere. So the nose piece is designed to allow something called as Coanda effect to achieve fluidic flip of the gas stream during exhalation. So part of the gas that is coming in through the bias flow through one of the tubes is allowed to be pushed back through the other tube that is open to the atmosphere when the baby exhales away from the patient, leading to more even CPAP delivery. So this is how it looks like. So on the left side, we have the patient And we have two tubes, and one of them brings gas from the air oxygen source, which is the gas source. The other tube, which is connected to the atmosphere, during expiration allows some gas to flip back, fluidic flip back to the atmosphere. And during inspiration, because the patient is inhaling, this creates a negative pressure in this interface. And hence, the tube that is open to the atmosphere, in fact, entrails additional gas flows from the atmosphere. So we have the constant gas flow that is coming in from the gas source. In addition, we have additional gas flowing in from the atmosphere, effectively resulting in higher flow during inspiration. Whereas in exhalation, because of the fluidic flip, you have lesser than the bias flow that is coming from the gas source effectively going to this patient. So this is believed to reduce the baby's work of breathing. Now there are, in bubble CPAP, back to bubble CPAP, we have three knobs on the inspiratory circuit. These are the three knobs highlighted with the arrows. So I'm going to tell you the purposes of these three knobs, which is sitting just above the humidifier. So the first one is meant for as the pop-off valve, which is a pressure relief valve. When there is very high pressure, this pop-off valve opens and it releases the excess pressure. The second small knob here is the one that is going to be connectable to a pressure manometer to measure the actual delivered pressure to the patient. And the third one sitting right down is the knob that is meant for the connection with the FiO2 analyzer or an oxygen analyzer. So this helps us in measuring the FiO2 that is being given to the baby. So this is how it works. So if you're setting, say, 21% oxygen to the baby, this oxygen analyzer can be connected to the knob that we just saw, and it helps us to actually find out the concentration of gas that is going to the baby. So what are the indications of CPAP? The indications of CPAP include a baby with respiratory distress syndrome or TTNB or meconium aspiration syndrome, pneumonia, any baby who has respiratory distress, provided the baby has good, adequate, spontaneous respiratory drive. If a baby doesn't have enough respiratory drive, the baby is not a good candidate for CPAP. Some relative contraindications for CPAP are babies who are at high risk of apnea or poor respiratory efforts. CPAP is also not a very good mode for a baby who is hemodynamically unstable or in shock, where you would want to provide mechanical ventilation to the baby. And again, you may be a little wary about the use of CPAP in a baby with severe ppH. Most of these babies may require higher modalities such as pulmonary vasodilators, inhaled nitric oxide, and may benefit from intubation and mechanical ventilation. Indications for the use of CPAP, for indications for the use of oxygen analyzer while using CPAP, to monitor the FiO2 while the neonate receives oxygen, and to periodically check FiO2 delivered through the ventilator or CPAP. Now that's the flux meter. The clinical utility of a flux meter is to measure the irradiance that is being delivered during phototherapy. The ideal range of spectral irradiance while giving phototherapy is between 450 to 460 nanometer, and we must be giving a spectral power or spectral irradiance of at least 30 microwatt per centimeter square per nanometer of this wavelength range in order to achieve intensive phototherapy. Now, how do we interpret the reading that is displayed? Ideally, we must measure the flux, the irradiance delivered using the flux meter at all four corners of the phototherapy's footprint as well as in the center, and then take an average to see whether this is lying in the optimal range. Now, the optimal range of spectral irradiance, which I just mentioned, is 30 microwatts, that's the power, per nanometer of bandwidth per centimeter square of the exposed body surface area, which is what is qualifying for intensive phototherapy. The next equipment that we'll see is the therapeutic hypothermia device. So this is a device that brings down the core temperature of a baby who is had some neurological insult to the brain in order to achieve neuroprotection. And there are two types of therapeutic hypothermia devices. There can either be whole body cooling devices, or you can have selective head cooling devices. Now, whole body cooling devices are machines that help in wrapping the entire baby and result in cooling of the core body temperature, resulting in effective cooling of the deeper brain structures of the baby. Whereas in the selective head cooling devices, you only have cooling involving the superficial brain structures, and this may be perhaps slightly less effective than the whole body cooling devices. So let's discuss the indications, exclusion and inclusion criteria, as well as the mechanism of action. Now, the indications or inclusion criteria for therapeutic hypothermia include babies with gestational age more than equal to 36 weeks, with either an Apgar score which is low, or the presence of cord metabolic acidosis, or and the presence of moderate to severe encephalopathy. Now, infants are considered to be eligible if they are more than 36 weeks, with either an Apgar score of less than or equal to 5, at or beyond 10 minutes of life, or the presence of cord, arterial or capillary acidosis with pH less than 7 and base deficit more than equal to 16 millimoles per liter within 60 minutes of life, as well as the presence of moderate to severe encephalopathy. We do not prefer to ideally cool babies who are more than 6 hours of age at the time of admission or initiation, with the presence of major congenital abnormalities that may require surgery, or the presence of lethal chromosomal abnormalities or syndrome. So these babies are not to be cooled. We only cool infants who have had severe perinatal asphyxia, which satisfy these criteria. So either a low Apgar score at as long as 10 minutes, the presence of metabolic acidosis, pH less than 7, base deficit more than equal to 16 within 60 minutes of life, and the presence of moderate to severe encephalopathy. We'll have to qualify the presence of moderate to severe encephalopathy based on a standardized scoring tool like Sarnath and Sarnath staging or Thompson's staging. And this is something that needs experience and training. There are various devices that are used for cooling. It can be either high-tech or the low-tech devices. The high-tech devices include the servo-controlled blanket-roll, Ticotherm, Criticool, Cool Cap, and low-tech devices include natural cooling with a refrigerated gel pack, water bottles, fans, gels, and paste-changing mattresses. Now, what are the mechanisms of cooling? Now, cooling helps by reducing the brain metabolic rate by at least 5% for every degree centigrade drop in temperature. It reduces glutamate release and production. It also reduces generation of reactive oxygen species. It upregulates the cell survival pathways or the anti-apoptotic pathways and anti-inflammatory effects by reduction in the pro-inflammatory cytokine and favoring of anti-inflammatory cytokine activity. It reduces cerebral blood flow linearly with decreasing temperature, and coupling between there is constantly a coupling between cerebral blood flow and metabolic rate. These are various trials that have been performed on cooling, and I shall not get into the details. Now, any baby who is receiving therapeutic hypothermia should also be given good supportive care, because it is not just going to be cooling, but it also relies on providing anticonvulsants for seizures, providing the right inotropes for shock and analgesia, or painkillers such as fentanyl and morphine for providing gentle supportive care. So we have discussed that therapeutic hypothermia is only reserved for babies more than or equal to 36 weeks who have suffered from perinatal asphyxia, who also have some predetermined fixed criteria in the form of Apgar scores, which are low at 10 minutes of life, the presence of metabolic acidosis in the cord, blood gas, or immediate postnatal gas, with the presence of moderate or severe encephalopathy. At present, therapeutic hypothermia is not recommended for newborns who have had hypoxia with mild hypoxic ischemic encephalopathy. Let us now discuss about the role of transcutaneous bilirubinometer for the detection and management of jaundice. Now, what are the principles of TCB? Transcutaneous bilirubinometry relies on the presence of the principle of spectral reflectance. So it relies on placing the probe of the transcutaneous bilirubinometer over the infant's forehead or over the sternum, that is the chest. And spectral reflectance is used for measuring the levels of bilirubin in the skin. The normal sites of measurements are either the forehead or the sternum or the chest. And common limitations of TCB include that the role of TCB is still limited in preterm infants with clinically significant jaundice, especially infants less than 35 weeks. But now there is more and more data coming in that it can be used even in preterm infants. However, some of the other limitations still remain, such as infants less than 24 hours where TCB is not reliable, infants with hemolytic jaundice or other significant risk factors for jaundice like ABO, Rh immunization, newborns who are having hemolysis due to other reasons, Term infants where PCB reading is more than 250 micromoles per liter. Now we should remember that 17 micromoles per liter is equal to 1 milligrams per deciliter of bilirubin. So usually if the value of the serum bilirubin, if I have to put in milligrams per deciliter, if it's beyond 13 or 15 milligrams per deciliter, then we always prefer to go for a serum bilirubin. Likewise, TCB is limited in a baby who is already receiving phototherapy. Now, the other interfering substances that come in the way in our measurement of the transcutaneous bilirubin value would be melanin, hemoglobin, as well as dermal maturity. So, due to this reason, infants who have crossed 14 days of life, postnatal age, they don't reliably get their values assessed with the transcutaneous bilirubin. The next question, an equipment that we commonly use is the phototherapy equipment. So what are the mechanisms of phototherapy? What are the types of phototherapy units? And let's discuss some practical tips. So the three common mechanisms of action of phototherapy are configurational isomerization and structural isomerization, as well as photooxidation. So now configurational isomerization refers to the process wherein the photoisomers, the bilirubin isomers are converted into water-soluble isomers that can be easily excreted in the urine and stool. In structural isomerization, bilirubin is usually converted into a water-soluble product in the form of lumirubin. This is a irreversible change, and this is one of the most effective mechanisms of phototherapy, whereas photooxidation is a fairly less effective mechanism of phototherapy. Now, there are different types of phototherapy units. This is the more conventionally used CFL or conventionally used a special blue Philips CL lamp, which is generally effective for around 1200 hours. And it has a very wide wavelength range from 400 to 520 nanometers. Whereas most of the units now use the LED lamps or the light emitting diodes, which are made up of gallium nitride crystal. The LED lamp, in contrast to the compact fluorescent lamps or CFL lamps, they emit less heat. They also emit less infrared light and ultraviolet light. So they cause less environmental pollution. They also result in less heating of the baby. They are power efficient. They consume less power as well. So they have so many advantages that most units now prefer to use them. They also last for a longer time, for as long as 10,000 hours, and hence the need for changing lamps and all that doesn't come into place. Now, the tips for effective phototherapy are to increase the exposed body surface area of the infant under phototherapy by placing another phototherapy unit beneath the side of the unit by the infant, or placing reflective material around the incubator and keeping the diapers as small as possible. And we may also benefit by keeping the phototherapy unit as close as possible, up to 15 centimeters. Side effects of phototherapy include the presence of dehydration, fever, retinal damage. There can be rapid changes in the organ systemic blood flow. Cerebral blood flow may sometimes increase, leading to intraventricular bleeds. And sometimes we may see that in preterm infants, a large PDA or the PDA may convert into a hemodynamically significant PDA. And some other minor side effects such as phototherapy induced diarrhea or loose stools, which may persist for a very long time. Now, the next common equipment that is used is the syringe pump. Though there are different types of syringe pumps, starting from the drip rate pumps as well as the proper infusion pumps. So this is the table showing that there are gravity control pumps like the drip rate regulators, drip rate controllers, and the positive displacement pumps like volumetric pumps, syringe pumps, multi-channel pumps, and ambulatory pumps. Syringe pumps are often used in neonatal units because we require precisely calculated volumes of infusion to be given to the newborn, especially the smaller low birth weight newborns. So we have volumetric pumps, which are shown on your left side, and the syringe pumps or infusion pumps that we see on the right side. Each of them have its own features. There are different reasons why we see alarms in syringe pumps. You see a pre-occlusion as well as a proper occlusion alarm when there is any obstruction to the PMO line going to the baby. We may also see alarm because of the end of the completion of the infusion, which is called end of infusion alarm. Syringe pumps also alarm when there is a battery fluctuation, or when they are running on battery, when they are run out of battery, or if they have been disconnected from the power source. So these are some common alarms that we see in the syringe pumps. So this is one of the most commonly used equipment in the neonatal ICUs. Next, we'll discuss about CFM or amplitude integrated EEG. Now, in recent days, the cerebral function monitor has come up in a big way, and this machine helps us to monitor something called as amplitude integrated EEG, which is one of the forms of monitoring the neurophysiology of the baby. And it helps us to identify different clinical applications and patterns of encephalopathy in the baby. So this is how it is different from a regular EEG. So you all have seen a regular electroencephalogram, which is a 16 lead multi-channel reading, which is obtained by connecting 16 different leads, and these are all the different placements, starting from the frontoparietal leads, frontal leads, the central, parietal, occipital leads, temporal leads, etc. So each of them have an odd number and an even number based on the site to which they are connected. Now, in contrast to the conventional EEG tracing, the amplitude integrated EEG tracing, which is got primarily from biparietal leads only. In fact, there are total of 4 leads. 2 of them are the biparietal leads, which are placed on either side of the baby's head. And we have a neutral lead as well as a grounding electrode. So we have a grounding electrode, a neutral electrode, and the 2 biparietal electrodes. This is all we need for the amplitude integrated EEG. Now, how does the amplitude integrated EEG differ? This is electroencephalogram, which is derived in a semi-logarithmic sort of scale. So it starts from 5 and then 20, 25, and then the scale rapidly increases. It converts the EEG, the traditional EEG, from the negative and positive deflections entirely into the positive deflection. So it's kind of called as a rectified graph. It also is compressed in time, and it amplifies the electrical potentials that are derived from these biparietal leads. So in other words, this is a amplified, rectified, semi-logarithmic scale compressed form of EEG, which generally runs at the speed of 1 hour within 6 centimeters. So you might be able to see many hours of EEG tracing within a short waveform like this. So normally the bandwidth reflects the variations from the minimum to the maximum amplitude in a conventional EEG, where in EEG, the bandwidth that you see is the variation between the minimum and the maximum. So greater the bandwidth, it means that the variation was quite high. And the amplitude display is linear between 0 to 10 microvolts, and then it becomes logarithmic from 10 to 100 microvolts. Semi-logarithmic display enhances the identification changes in low voltage activity and avoids overloading of the display at high amplitudes. So these are the 3 important measures in EEG. So it measures the minimum and the maximum amplitude of the display, as well as the variations in amplitude, which is called as cycling. So what are the different normal and abnormal patterns of EEG? So in the typical normal trace, we must be able to see a lower margin, the minimum margin, which is more than 5 microwatt, and the maximum margin, which is about 10. And the mean is around 25 or so. So normally you will see something like this, where the minimum margin is definitely above 5. Maximum may go to something like 20, 25, and hence the mean is going to be around 25 microvolts. So the upper margin is about 10 and the lower margin is at least above 5. This is a normal trace. A moderately abnormal or discontinuous normal voltage EEG, the AEG waveform is a waveform where the lower margin is below 5 and the upper margin is above 10. So here the lower margin drops down, but the upper margin is still above 10, resulting in a wider bandwidth than usual. This is called as a discontinuous normal voltage EEG. In severely abnormal pattern, which can be an isoelectric or burst suppression pattern, the lower as well as the upper margins have come down very low, but we see occasional bursts of high amplitude, which are seen in the AEG waveform. And this is called as a severely abnormal pattern. Now, the clinical application of AEG is that it helps us in early identification of encephalopathy, and hence it is easy or helps us in classification of asphyxia as mild, moderate, and severe, and for the initiation of therapeutic hypothermia if needed. It also helps us in early detection and treatment of seizures, and for the monitoring of response to anticonvulsants. And the prognostication is also possible by the normalization of AEG by around 48 hours. The final equipment that we'll be seeing for the day will be this, which is the flow sensor in a ventilator. Now, flow sensor is a device that helps us to detect the patient's breathing and helps the ventilator to synchronize the delivery of the breaths with the patient's breathing. There are different types of flow sensors, starting from the abdominal movement sensors or the thoracic impedance sensors. The abdomen movement sensors are also called as applanation tonometers or 𝗲𝗎 capsule. These used to come with the previous ventilator called Infant Star, which is now phased out. We often use flow sensors. Now, these are devices that help us to detect flow that is generated by the inspiratory effort of the patient, the baby. They can be of two types. You can either have a heated wire anemometer or a differential variable orifice, which is also called as pneumotachogram. The heated wire anemometer has a series of heated electrical filaments which get cooled with the baby's inspiratory flow. And based on the drop of temperature in these electrical filaments, the ventilator can calculate the flow rate in liters per minute. So, for example, if you have some decline in temperature, say the flow rate is going to be 200 mL per minute. If there is a greater decline in temperature, the flow rate could be 500 mL per minute. Now, heated wire anemometers, although they are very, very sensitive flow sensors, they can detect the smallest of flows across the sensor. They are also very vulnerable to a lot of auto-triggering or artifactual triggering. And artifactual triggering can often happen with non-respiratory movements like hiccups from the patient. It can also happen from condensation of the humidification, condensation of water droplets on the flow sensor, which can also lead to a drop in temperature. The other type of flow sensor, which is the pneumotachometer or differential variable orifice flow sensor, has a series of tubes of fixed internal diameter and fixed length, which detect the pressure change from the ends of the tube. So based on the pressure differential and the fixed resistance that is offered across the tube, we can calculate the flow. So we kind of back calculate the flow because we all know that flow is directly proportional to delta pressure divided by the resistance. In this case, we know the delta pressure as well as the resistance, and hence we are calculating the flow. So this is a table comparing the different flow sensors. Both the thoracic impedance meters and abdomen motion sensors are all relatively late sensors, late detectors of the baby's respiratory effort, and hence they have greater trigger response time or trigger delay. However, they are technically easy to use, but they are not in vogue these days. The flow sensors have lesser response times and they are more sensitive because they detect the respiratory efforts very early when the baby starts inhalation. And they also give the advantage of measuring the tidal volume, and hence they come into play for volume targeted ventilation. But they are extremely sensitive, leading to the problem of autocycling or artifactual triggering. On the other hand, the airway pressure monitors work on the principle of pressure transducers, which come with a trigger delay of 40 to 100 seconds, are easy to use, and have higher trigger thresholds. So with that, I kind of conclude this session on OSCEs and different equipments. I'll be glad to take up any of your questions, any of your doubts. Please post them to the Dr. Doral's team, and we'll get back to you with the responses. I'll come back to you with typed responses as early as possible. Thank you so much.
Close the session.
Yeah, we have finished.
Okay, man. Then close చేస్తున్నాను.